Hi there. When you walk into a home health visit and your patient with cancer says, "Oh, my pain is just getting worse and I'm not sleeping well at night," and the family just looks overwhelmed, medications aren't working the same anymore, and you think, what do I chart so Medicare understands this is still a skilled nursing? Let's break it down using a simple framework. Condition, the risk, skilled action, response, and continued need. Imagine a patient with advanced cancer is receiving palliative home care. During the visit, you observe increasing pain levels despite current medication regime, fatigue and decreased appetite, nausea that's affecting oral intake, and family unsure how to manage breakthrough symptoms. Medication side effects are unclear or even unmanaged. Most nurses document pain-controlled, continue current plan. But palliative care is not about static stability. It's about symptom management in a changing high-risk environment. So step one is the condition. Ask yourself, what is the most significant clinical issue today? In this case, it's the uncontrolled or fluctuating cancer-related pain. Symptom burden, fatigue, nausea, weakness, progression of the disease process affecting the function. It's not just the cancer, it's active symptom instability requiring ongoing management. Well, step number two is the risk. Ask yourself, what bad outcome could happen if this is not managed? The patient is at risk for uncontrolled pain crisis, severe symptom burden affecting quality of life, and dehydration, malnutrition, medication side effects, or even toxicity, emergency department visit for symptom control, caregiver burnout and inability to manage the care at home. Now the focus shifts from diagnosis to system risk. Well, number three is the skilled action. Why is a nurse needed in the home? Well, a caregiver can administer medications, but a nurse can assess pain using clinical tools and observation. They can evaluate the effectiveness and the timing of current medication regimes. And they can identify side effects versus disease progression. And they can adjust care plan recommendations through the scope of and provider orders, and provide structured system management education. And they can support caregiver in complex medical decision making. That is the skilled nursing in palliative care. Today's skilled actions may include comprehensive pain and symptom assessment performed, the evaluation of medication effectiveness and breakthrough usage, and education on scheduled versus PRN management strategies for pain control, and instruct on maybe some non-pharmacological measures, caregiver education on recognizing uncontrolled symptoms, and communication with the provider regarding the symptom escalation. The fourth step in this is the response. What happens because of your intervention? Maybe the patient reports partial relief after medication timing adjustments. Caregiver demonstrates improved understanding of when to administer the PRN medication, and family still expresses anxiety about symptom control. Documenting clearly, in palliative care, response is often partial improvement, not resolution. What is expected? Well, in step 5, the continued need. Why are future skilled nursing visits still necessary? Well, the patient continues to demonstrate progressive disease processes, unpredictable symptom fluctuations, and complex medication management needs, high caregiver burden, and ongoing need for assessment and adjustment of comfort strategies. The support continues as the skilled nurses providing these services. So putting it all together, now let's run it into a clinical narrative. Patient with advanced cancer noted to have increased pain intensity despite current medication regime. Reports poor sleep and increased breakthrough pain episodes. Skilled symptoms assessment performed including pain evaluation, medication review, and assessment of side effects versus disease progression. Current medication regime evaluated in effectiveness and timing. Education provided to patient and caregiver regarding the scheduled versus the PRN pain medication use, non-pharmacological comfort measures, and strategies for managing breakthrough symptoms. Caregiver instructed on signs of uncontrolled pain, when to contact the provider or hospital palliative team, and communication initiated with provider regarding the escalation of symptoms, burden, and potential need for medication adjustment. Patient reports partial relief with current regime, but continues to experience fluctuating symptoms. Continued skilled nursing required due to the complex symptom management needs and the progressive disease process and caregiver support requirements. The Medicare reviewer takes a look at this and they look at the condition. They see the progressive cancer with symptom instability. They see the risk, uncontrolled pain, the hospitalization potential, the medication complication, and caregiver breakdown. The skilled need, symptoms assessment, clinical judgment, medication evaluation, and caregiver education. And then they look at the skilled intervention that's going on, pain management support, monitoring the condition, and teaching. And the continued need. Symptoms are unstable and require ongoing skilled oversight. So in closing, the next time you document a palliative or cancer patient, just don't focus on the pain assessment medication given. Ask yourself, what is the condition? What is the risk? Why was a nurse needed, and what skilled action occurred, and why are future visits still necessary? When you think this way, your documentation becomes more than just task-based care. It becomes clear evidence of skilled nursing support for complex, changing, and high-risk symptom management in the home. Well, I hope this has been of benefit to you. If you'd like more resources, you can check out my website, or I don't have a website yet. You can check out my YouTube channel for resources there. And I hope you have a great day and see you on the next one.